Today we're going to be testing the suction unit. To do this, we fully include the tubing close to the bowl. We then turn the machine onto full and press test. Here we wait for the lights to reach the top and the machine to turn off. Now that's turned off, that means that we have a closed circuit. In regards to using the catheter on a patient, we will only ever insert the catheter as far as we can see, being careful of any of the soft tissue inside of the mouth. From there we will depress on the catheter here to create a suction. In circular motions, retract for a maximum of 10 seconds. Some of the contradictions of this is that it can induce vomiting and bradycardia. Hypoxia and aspiration is another major concern, along with laryngospasm. Today we're going to talk about oxygen delivery, the different components, and how to identify it as oxygen itself. So the bottle will be white in colour, it should be labelled, and also will have 3 prongs on the top here. Then we will take the regulator itself. First we will check the Bodoc seal is intact, which it looks to be. Then we will slide this over the top, lining up the 3 prongs and tightening the regulator to the bottle, like so. Here we will turn the top of the valve on, and that should open the oxygen into the regulator, like so, and we can see that we're above the green, which is 2,500 kPa. It says that there is oxygen in the bottle sufficient. We can also test the flow rates, which is with this end valve here, and go quarter, half, 1, and so on, all the way through. That lets us know that it is all working correctly. It's always best to lay a bottle flat on the ground for safety. Here I have a Hudson mask. There is multiple different masks or oxygen delivery units, one being nasal prongs, another being a nebulizer mask, but today I will be using a Hudson mask. Here we use this at 60% oxygen at a flow rate of 6 to 8 litres per minute. We can place that on like so, that up, turn that to our 6 litres per minute. On the patient, we will place that over their nose and mouth, lifting the elastic, ensuring that it doesn't go across their ears. To turn that off, we'll take that all the way back down to 0. We can take the tubing off, and to purge the line, we can then close the bottle back off, like so, and then purge it through this end valve here. And that allows the pressure to drop out. Once that happens, we can undo the valve all the way out and remove this off. Today we're going to test the LifePak 12 and show you how to work with it. To start with, we first of all want to check the battery content. Here we can check the levels. This is on 1 bar, so that's on low battery. This one here is on 3 bars, that's sufficient. From here we can turn LifePak on by pressing on. It's going to go straight into defib mode, which we don't want at the moment, so we can press advisory. From here we're going to scroll across to yes, into manual mode, like so. Once this is done, we can press options and go into the user test. As this user test is in sequence, we can check the other pockets and show you what's in here. BP cuff, defib pads, extra printer paper, ECG dots, and there's a CO2 monitor also in this back part. This pocket here has the test load, defib cable. Other important pieces here is a razor the GTN aspirin to help the patient. I can go ahead and connect this up to the test load like so. This pocket here has the SpO2 monitor, the 4 lead, which we can connect up to the patient, and also a 12 lead. Within the 4 lead, it's fairly simple. You have left arm, right arm, left leg, and right leg, which will go here, ensuring that they're not on a bony part of the patient, but a fleshy part. The printer has printed out a test saying that it's good to go. Right, from here we would like to test the load. We press Energy Select. We choose the joules that we want it on. I will take it down to 50. Charge now. And shock. The test load takes a shock. From here also, if we wanted to dump the load, we would press Energy Select, take it to 50 joules or whatever energy you wanted to. Yes. Sorry, there. Charging. And instead of shocking, we dump the load, we press this button. Dump the shock. Some of the other things that we can look at is to the size, ECG size. So we can go up and down through here and select which one we would like to go there. Also the lead size here, you press lead and you can scroll up and down to where you need to go. And then also we can go across to the top left corner to do the QRS volume, and by clicking on that, click on QRS again and you can increase the volume there so we can hear any audible sounds of the heart during this process. Okay, so we've got our first response kit. In this top pocket here we have blood pressure cuffs, adult and pediatric. We have tympanic meter, we have a BGL, stethoscope, eye torch, and also shears. This pocket here is just for other bits and pieces, and also the ICP if he needs to put his drug kit somewhere. We have in this top pocket our meds, which is the methoxyflurane, Panadol, Tramadol, ondansetron, ibuprofen, and also Loratide. Then we have our HAZ bags, our laryngoscope, our OPAs, NPAs, forceps, and gel to help lubricate those. We come down into these masks here, which are our Hudson mask and our nebulizer mask, as well as the nasal prongs, and these are the drugs with them: the salbutamol, ipratropium, and adrenaline. There's also some prednisone in there as well. This long pocket is our trauma pocket, all our bandages, our tapes, saline for irrigation, tourniquet. Come across to the next outside pocket. So for blood glucose, we have a glucagon pen. This is glucose 500 mils for infusion. Also glucose suckies just to bring up your blood glucose level. This pocket here, we have our vomit bag, topical anesthetic spray, and cervical lanyard, along with the N95 masks. Then we jump inside, we have a slippery sand, we have more IV fluids, we have sharps, we have a rolled up towel. We have a cervical spine collar and also splints. Then we have a pediatric BVM for airway, the adult BVM airway here, and some LMAs and the IV roll for any intravenous access we need. Now I'll show you how to use and test the BVM mask. So here we bring BVM out, also the reservoir, attach the reservoir like so, occlude the valve. By doing that, we know that there's no splits within the main bag itself. We change that over and we inflate the reservoir like so. We can see that there's no splits there, so we're good to go. Okay, so now I'm going to show you how to insert and measure an OPA and an NPA. what we're going to be looking for is making sure that we choose the right one. We're going to be measuring from the mouth to the angle of the mandible, like so. Knowing that we have the right one, we will insert it upside down, like so, and then rotate it 180 degrees into the patient's mouth, like that. With the MPA, similar, we will choose the MPA, we will measure from the nostril to the earlobe, like so. This will be lubed up and then inserted 90 degrees to the patient's face and slid down until it reaches the nostril. Contraindications with the MPA are that you can create trauma within the nasal cavity via soft tissue damage and injuring nasal polyps. You would not be doing an MPA if the patient had a brain traumatic injury. With the OPA, we would want to make sure that you don't do any soft tissue damage on the way in, and also you can touch the epiglottis in the back of the throat, creating a gag reflex which will create aspirations into the patient's lungs. Okay, my partner and I, we've been called out to a possible resus at AUT grounds. Upon arrival, we noticed that it's quite a distance from the car park to the building, and also the ingress and egress to the room itself is going to be difficult because there's a set of stairs. The weather's not going to play a part as it's inside. As we get up the stairs, you'll notice that we both are wearing our PPE, our glasses, our gloves, our boots, our uniform. We enter the room, we see that there are multiple bystanders who I will be asking to leave if they're not applicable to the patient, and also that there's a good zone around the patient for us to work in and it's nice and flat. Do you feel safe, Janet? Yes. Okay, when we enter, can you please put the gear beside my feet and open up the defib? We will treat this as a resus. Okay. Okay. Hello, sir. Sir, can you hear me? Hello? Hello? Okay, there's no response to pain or voice. We're going to check his airway. We're going to do this via a head tilt chin lift. There is nothing obstructing his airway. I'll then check for breathing, any signs of breathing. By doing this, I'll have my hand on his chest and my cheek to his face. 10 seconds. There's no breathing. Okay, can you get on to compressions, please? Okay, AUT1 to comms, requesting, it's an R49 requesting R50 backup, please. Stand back, please. As we analyse this, I'll get the BBM ready. Get on compressions, thanks. Okay, as this is charging,
clear of patient.
We will wait for it to charge, and then we can deliver the shock.
Now,
I'm clear, Janet's clear, everyone's clear. It's shocking.
Shock
Delivered, back on. Thank you. Okay, so now we have
Start CPR.
the oxygen setup. I'll also be sorting out an OPA. From here, I will be placing the OPA in upside down, rotating 180 degrees into the patient's mouth. Count me down, please.
25, 26, 27.
30. The C grip, CE grip. Making sure that the chest back on compressions, the chest is rising, there's no gastric inflation, and that ensures that there's no thoracic pressure increase there to the patient. Also be doing a NPA. To do this, we lube it up, and we will be going 90 degrees to the patient's face. We will insert that all the way down until it reaches the nostril. Get it down.
25, 26, 27, 28, 29, 30.
Okay, good. Not doing the full bag, only a third of the bag. Back on compressions, please. That's really good, Janet. So we're making sure that the compressions are a third of the chest, nice and deep, and the recoil is good. This allows the heart to fill with blood, and the patient gets the optimal beat of the heart. The bag here, the reservoir will be filling. As Janet is doing that, we will be, after the next round, we'll swap to ensure that I'm giving my partner a rest. Are you okay?
Yes.
Count that down.
25, 27, 28, 29, 30.
That's good inflation. Back in the compressions, please. The next one, when Janet comes, she'll be doing the CE grip, which is the jaw thrust. Hold the mask back.
Stop CPR.
Stop.
Analyzing heart rhythm.
Analysing this change.
Stay clear of patient. Analyzing heart rhythm. No shock advised.
Okay,
Pause.
back on. From the armpit up
If
through the
needed,
nipples,
start
making
CPR.
sure that they're nice and deep. Zero, 28, 29, 30. Okay, breathe. Okay. From here, I can ask questions from bystanders. Please count my compressions. Janet, has anybody seen what happened today?
14,
Does anybody know this patient?
20, 21, 22, 24, 25, 26, 27, 28, 29, 30.
How long has this patient been like this? One, count them, please.
5, 6, 7.
By asking
9,
these questions, we're gaining a medical history from the patient and possible other indications as to why he is like this.
28, 29, 30.
By getting to the scene on time, defib and compressions, this is giving the patient the optimal chance of survival.
20, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30.
The only reason why we would stop is if we were too fatigued to carry on, or if there was return of spontaneous circulation to the patient, or if there's any visible movement.
28, 29, 30.
The next one, can you do a double CE grip, please? Okay, from here, I can then breathe for the patient. 1, 2.
Stop CPR.
I think I've got a pulse.
Analyzing heart rhythm.
Yep.
Stay clear of
Oh,
patient.
no, sorry, it's my phone.
Shock advised.
Sorry.